Shall we start?
Good afternoon, everyone. We welcome all of you on behalf of Satluj Academy of Pediatrics, State IIP Chapter Punjab 2026 on monthly case presentation series. This month we have excellent team under the leadership of Dr. Hijot Patel sir, moderator Dr. Amardeep Kaur, presenter Dr. Dipanshu Garg, and expert team senior pediatric intensivist Dr. Vikas Bansal, Clio Mother and Child Institute, Ludhiana. Welcome all of you on the case presentation. Now I hand over to Dr. Harjot Bhattal to formally start the meet. And for the further proceeding, I also acknowledge presence of senior pediatrician Dr. Tarlochan Singh Dawa sir. Thank you so much for joining the session and all the residents delegates who joined for today's session. Over to you, Dr. Harjot sir.
Good afternoon, everybody. I welcome on behalf of Adesh Medical College Department of Pediatrics. So we had a very interesting case we managed approximately 8 to 9 months back, and the child is also readmitted again and again. So we have just kept the heading small A with big impact. So that was journey of an infant with the diagnosis of post-infectious bronchiolitis obliterans. So now our PG resident will tell you the details of the case and we will discuss later on.
So Dr. Dipanshu, yeah, please make it a slideshow. Yeah.
Good afternoon, everyone. Myself is Dr. Dipanshu. I am here to present the case of bronchiolitis obliterans. I would like to welcome our experts, Dr. Vikas Bansal sir, Senior Pediatric Intensivist at Clio Mother and Child Institute, Ludhiana. Our mentor, Dr. Harjot Bhattal sir, Professor and Head at Department of Pediatrics, Adesh Institute of Medical Sciences. Our moderator, Dr. Amardeep Kaur, Professor at Department of Pediatrics, Adesh Institute I am presenting a case of 1 year second non-consensuous history, resident of Dhangad, Barnala, admitted on 3rd of August 2026 and discharged on 12th of August 2026. Informant is mother. She is reliable. The child presented with chief complaint of fever for 2 days, cough for 1 day, and difficulty in breathing for 1 day. The child was apparently well on regular treatment until 2 days before admission, when he developed acute onset intermittent high-grade fever. The maximum documented temperature was 102 Fahrenheit. Fever decreased after antipyretics but recurred. It was not associated with rigors. Child also had cough for 1 day. Before admission, the child developed cough that was progressive, wet, non-paroxysmal, and was associated with noisy breathing. There was no history of post-stressive vomiting and no significant diurnal or postural variation. The child developed difficulty in breathing in the form of fast breathing and chest indrawing. It was not associated with any feeding difficulty or bluish discoloration. There is no history of cough or choking during feed, vomiting, or any foreign body aspiration. No history of TB contact or prolonged cough in any household member. No exposure to smoke, chula, biomass fuel, dampness, mold, pets, or cattle. No recurrent ear or ear skin infections, oral thrush, or foul-smelling greasy stools. This is the journey of the child in a nutshell that we'll be discussing in further slides. The child had first episode in the January 2025 when child developed severe respiratory illness at the age of 3.5 months, for which initially child was managed in private hospital conservatively and was referred to PGI Chandigarh in view of worsening of respiratory distress, where adenovirus was detected in respiratory viral panel, and child was managed in PICU on HFNC and oxygen support. The child was discharged after 1 month, but got readmitted within 8 hours when child was managed in PICU on mechanical ventilation and discharged on home oxygen. 17 days later, admitted to Adesh Hospital and was managed in PICU on mechanical ventilator and discharged on home oxygen after 2 weeks. Child then again got admitted in 15 days. Later, readmitted in Adesh Hospital in pediatric ICU and was managed on HFNC support. Child was then again discharged on home oxygen after 1 week. Course during first admission. Child was admitted at PGI Chandigarh on 25th of January 2025 in view of worsening respiratory distress and was managed in pediatric ICU on high-flow nasal cannula support along with nebulizations, injection ceftriaxone, oseltamivir empirically, and cidofovir in view of respiratory viral panel positive for adenovirus. In view of persistent respiratory distress, pulmonology opinion was taken and possibility of resolving pneumonia and post-infectious bronchiolitis obliterans was considered. In view of elevated BP readings, TAP enalapril was started. Workup done showed normal 2D echography and renal Doppler findings. So the child improved with salbutamol and budesonide nebulizations and was discharged on oral prednisolone, montelukast, and alternate day azithromycin on 24th of February 2025. But respiratory distress recurred within 8 hours of discharge, so child was readmitted in emergency at PGI and was again managed conservatively. HRCT chest done showed mild bilateral hyperinflation with mosaic pattern and right upper lobe consolidation, supporting the diagnosis of post-infectious bronchiolitis obliterans. Bronchoscopy was done and bronchoalveolar lavage sand showed growth of Klebsiella pneumoniae and Acinetobacter baumannii, which was managed as per the sensitivity pattern. On day 10, the child became lethargic with worsening respiratory distress, stridor, and persistent wheeze. ABGs showed type 2 respiratory failure, therefore, the child was put on mechanical ventilation. Mechanical ventilation required high inspiratory pressures because of markedly increased airway resistance, episodic desaturation, bilateral wheeze, and severe bronchospasm was treated with continuous nebulizations with salbutamol, ipratropium bromide, injection hydrocortisone, magnesium sulfate, and aminophylline infusion was also started. Gradually, the child was weaned off to minimal ventilator settings and the child was extubated to high-flow nasal cannula and then to nasal bronchs with stable oxygen saturations. Child was discharged on oxygen support along with oral prednisolone, alternate day azithromycin, on nebulizations, estelin and budesonide, antihypertensives, tab labetalol, losartan, and amlodipine. In view of post-infectious bronchiolitis obliterans with history of lower respiratory tract infection with adenovirus positive in nasopharyngeal swab RT-PCR with prolonged respiratory distress with episodic worsening in CD4 to CD8 ratio of 0.2 and characteristic CT chest scan findings, pulse dose methylprednisolone was given followed by oral prednisolone at 2 mg per kg per day. Tab azithromycin for anti-inflammatory was continued on alternate day basis along with tablet montelukast with final diagnosis of post-adenoviral bronchiolitis obliterans with stage 1 hypertension. The child was brought to emergency after 2.5 weeks with chief complaint of fever for 1 day and difficulty in breathing for 10 hours with examination findings of heart rate 150 per minute, respiratory rate of 52 per minute, temperature of 101 degree Fahrenheit, SpO2 of 92% of oxygen support with subcostal retractions and nasal flaring, feeble pulses and cold peripheries. On auscultation, bilateral air entry was decreased and bronchi was present. Child was managed in pediatric ICU on HFNC and inotropic support. ABG sand showed type 2 respiratory failure with pH of 7.29, PCO2 of 61.3, PO2 of 99.9, lactate of 0.9, and bicarbonate of 28.6. So child was intubated and put on mechanical ventilation. Child was managed with supportive care, nebulizations, and IV antibiotics. BP readings remained elevated, so antihypertensive medications were continued. CBC sand showed hemoglobin of 8.5, so PRBC transfusion was given. TB workup was done, which was negative. Gradually, ventilatory settings were tapered and child was extubated to HFNC on day of admission 4, followed by gradual weaning to oxygen by nasal prongs. The child was discharged after 16 days on oxygen by nasal prongs and OG feeds and on azithromycin, nebulizations with Livolin, Budecort, ipratropium bromide, and antihypertensives tab losartan and tab amlodipine, with diagnosis of post-infectious bronchiolitis obliterans with acute exacerbation, shock, respiratory failure, hypertension stage 1 and moderate anemia. The child again got readmitted after 3 weeks on 15th May 2025 with similar complaints of fever, productive cough and noisy breathing for 2 days with findings of respiratory rate of 66 per minute, retractions and bilateral wheeze, saturation of 96% on oxygen by nasal prongs. Child was managed with HFNC support along with nebulizations and injection myself, IV antibiotics and supportive care. Chest X-ray was done which showed bilateral infiltrates. HRCT done showed bilateral ground glass opacities with consolidation, wall thickenings and bilateral atelectasis. 2D done was normal. This is the HRCT chest done which showed multifocal bilateral peribronchovascular ground glass opacities with confluent consolidation and air bronchograms, mild bilateral lower lobe peribronchial wall thickenings, and mild basal atelectatic changes. Treatment with azithromycin and antihypertensive amlodipine and losartan was continued, and nebulizations were tapered as the respiratory distress was settled. Child was then discharged on oxygen by nasal prongs. On 23rd of May 2025, this is the child again got readmitted on 16th of July 2025 when child had fever, cough and breathing difficulty for 1 day and was managed in PICU on oxygen support along with IV antibiotics and supportive treatment. In view of persistent fever spikes, urine culture was sent which was positive for Klebsiella pneumoniae and was started on IV antibiotics as per the sensitivity pattern. This time the child was weaned off to room air and was discharged on antihypertensives, MDI, and azithromycin on alternate day basis. Child was discharged after 2 weeks with final diagnosis of known case of post-infectious bronchiolitis obliterans with hypertension stage 1, pneumonia, and urinary tract infection positive for Klebsiella pneumoniae. Birth history. Antenatal period was uneventful. It was a term gestation born at 38 weeks of POG with cesarean section done in view of malposition with birth weight of 2.15 kg and cried immediate after birth. Current development history of the child. Currently, the child can walk and runs with a development quotient of 80%. Fine motors, child can scribble with DQ of 68%. Child in language domain, child can speak bisyllables with DQ of 40%. In social and adaptive milestones, child can imitate household activities and ask for food with DQ of 100%. Immunization history, child is immunized up to 18 months as per the national immunization schedule. BCG scar was present on left arm. Family history, there is no history of known TB contact or upper respiratory tract infection or reactive airway disease, allergic rhinitis and skin allergy in any family member. Socioeconomic status, child lives in a joint family with 11 members and head of the family is grandfather, educated till 5th of class. Father and grandfather works on daily wages and earns up to 50,000 per month with per capita income of 5,000. And according to the modified Kuku-Swami scale, the family belongs to the upper lower socioeconomic class. Dietary history, child is exclusively breastfed for the first 3 months and was on formula feeds were introduced thereafter. Complementary feeding was started at 8 months. Currently, the child had calorie intake of 941 kilocalories with a deficit of 115 kilocalories and a protein intake of 8 grams with deficit of 3.3 grams. On examination, general condition was sick, triage of level 3 urgent, temperature was 103 degree Fahrenheit, pulse rate was 153 per minute, central and peripheral pulses were well felt, respiratory rate of 56 per minute with subcostal and intercostal retractions, SpO2 of 93% on nasal prongs, blood pressure was 136 by 80, mm of Hg measured in right arm in supine position was more than 99th percentile. Peripheries were warm.
I just want to intervene here. We have been mentioning blood pressure since the beginning of this case, even when the child was 3 months of age. And now again we are mentioning blood pressure higher 136/80, and I probably assume that the child is at right now it's around 18 months of age.
Yes.
So is it the right way to label this child hypertensive, just measuring NIBP intermittently and getting higher readings on NIBP and saying this child is hypertensive? Has it any time been confirmed with the help of invasive blood pressure? Because we all know that in very small children, this NIBP readings are most of the times false readings. We should not rely on that. So if we are saying this child hypertensive and if this child is on 2 antihypertensives since almost 1 year, at any given point of time his invasive blood pressure was checked?
So no, sir, the invasive BP readings were invasive BP monitoring was not done. Although
Yes,
sir,
it's
the
still
child was on regular OPD visits on a follow-up. During that, the BP readings were the antihypertensives were although tapered. This BP reading was at this follow-up was high.
What I always suggest is that if you are labeling a child less than 1 year of age as a hypertensive child, or even I'll say any child less than 2 years of age with weight is somewhere around 10 to 12 kgs, it's always best to first do invasive blood pressure monitoring before labeling them hypertensive and starting them on antihypertensives. Because as the case we have seen from the history, we didn't have any cause of hypertension, which is quite significant, and we rarely see hypertension in children less than 2 years of age without any cause.
Yes.
So let's continue.
Okay. Anthropometry. Weight of the child is 10 kg, ranging from 0 to -2 standard deviation. Length is 85 centimeters, ranging in 0 to -2 standard deviation. Head circumference is 47 centimeters, ranging in 0 to -1 standard deviation. Mid upper arm circumference is 14 centimeters, and weight for length is -1 to -2 standard deviation. On general physical examination, child is irritable with no facial dysmorphism. Pallor was present, and icterus clubbing cyanosis and with no icterus clubbing cyanosis and lymphadenopathy. Head-to-toe examination done was normal. On respiratory system examination, nasal flaring was present. Nasal septum was normal. Oropharynx appears normal with no enlargement of tonsils. Posterior pharyngeal wall was normal. Chest was elliptical in shape with bilateral chest movement symmetrical. Trachea was in midline. Nipples at same level. Subcostal and intercostal interactions with use of accessory muscles present. No scar mark or dilated veins were present. On palpation, all inspection findings were confirmed with no tenderness or local rise of temperature. Trachea was in midline. Apical impulse at left fourth intercostal space, lateral to the midclavicular line. Chest expansion was normal on both sides. On percussion, resonant note was present in all areas of chest, and on auscultation, biphasic polyphonic wheeze was present. CVS examination, S1, S2 heard was normal with no murmur heard. CNS examination done showed no focal deficit. On per abdomen examination was soft, non-tender with no organomegaly present. During current admission, child was managed in PICU on high flow nasal cannula support along with nebulizations and injection magnesium sulfate, along with injection ceftriaxone started empirically with diagnostic workup done, and E. coli sent me of fever spikes showed urinary tract infection with E. coli positive, and injection amikacin was added as per the sensitivity pattern. Hemoglobin was 7.7, so PRBC transfusion was done. The child was discharged after 9 days on room air. This is the current chest X-ray done, which is suggestive of hyperinflation. And this is the complete CBC. Initial HB was 7.7, and post-transfusion the HB was 10.8. Initial TLC count was 14,000, and repeat TLC count was 5,000. Other investigations done were within normal limits. Urine culture was positive for E. coli, more than 10⁵ colony forming unit per ml, and was sensitive for phosphomycin, nitrofurantoin, amikacin, colistin, and ceftazidime avibactam with aztreonam. The 2D echo done was normal. Status at the time of discharge: the child was discharged after 9 days of admission on nitrofurantoin, nebulizations with salbutamol, budesonide, and tiotropium, and tablet amlodipine and losartan. This is the picture of the child during current OPD follow-up. This is the case summary. Child had first triggered in January 2025 when the child had severe viral pneumonia and diagnosed with adenovirus positive on nasopharyngeal swab, and had recurrent wheeze and respiratory distress. HRCT done showed hyperinflation and mosaic attenuation, with supporting the diagnosis of post-infectious bronchiolitis obliterans. Was managed in PICU on HFNC and mechanical ventilation support, along with hypertension, anemia, and UTI. Currently, the child is hemodynamically stable on room air and on MDI, salbutamol, budesonide, and ipratropium. And the azithromycin was stopped after 1 year, and steroids were stopped in July 2026 after tapering. Final diagnosis was post-infectious bronchiolitis obliterans with acute exacerbation with hypertension stage 1. Thank you.
It was a nice presentation, but I just want to add few things here. Uh, the cases of bronchiolitis obliterans, as we all know, it's a small airway disorder. And generally, once you label obliterans, that means already some sort of fibrosis has set in. And most of the time, this is a non-reversible kind of a situation. And what happens is that most of these patients, they are sent home on home oxygen, and they don't thrive well, and they get multiple courses of steroids and multiple courses of antibiotics for day-to-day exacerbations. So, what we have to keep in mind once we are sending them home is that the patient, when a patient of small child, like this child got first symptom at 3.5 months of age. So here, what is the savior? Savior is the growth of the child, because as the child grows double of the weight, all the body organs and all the organs which are affected by the disease, they will also grow. And we should have this hope that as the new lung is formed, that will be a normal, and probably that will now take care of the child and will help the child to recover well and to live its normal life. If the same thing happens to a patient which is bit bigger age, like same thing happening to a child of 3 years of age, then the management is bit more difficult and it's more severe. And generally, they are sent home on moderate distress, mild to moderate distress, and we have to advise these patients that the child should not be taken out for like routine schooling and all. It should not be exposed to public gatherings and should not be taken out for normal social visits. The child should be staying at home. So, what two things makes most important impact in these children is, one is very good physiotherapy, which actually has to we have to mobilize the secretions, because the now smaller airways are fibrosed, your all the cilias are not uh, moving, and there are a lot of secretions are there, and that's why these children, they have a lot of conducted sounds, crept bronchi at any given point of time. So we have to tell them that a very good physiotherapy along with very good hydration of the child is very important. Now, how to maintain a good hydration? Good hydration is, we generally recommend these patients to take a lot of ORS, because ORS, what we have seen is that it's one normal thing which is very cheap, and it leads to very good mobilization of secretions, which we commonly see in other cases of chronic lung disorders, like a child of cystic fibrosis, where because of the disease itself, the secretions are so viscid. And what we have seen is that if you start giving them ORS, then the secretions, clearance of secretions become a bit more easier. So second part, which is very important, is nutrition, because we know as the child grows, as the child rapidly gains weight, this children, the new lung will be formed. The new lung will be formed in all the zones of the lung, and that is actually going to help the child from this, help the child to recover from this chronic lung disease. And third, another most important question is that we have labeled this child as a bronchiolitis obliterans. Yes, clinical picture was resembling almost as a bronchiolitis obliterans. But as this child has undergone almost 3 ventilations, and almost since last 1.5 years, this child is just going in and out of the hospital, we should also look at the other genetic diagnosis, where these children can have some mucociliary clearance defects or mucociliary movement defects. So I feel that these children should be subjected to genetic investigations like clinical exome sequencing also, where we should always suspect either cystic fibrosis or mucociliary dyskinesias as one of the common cause, which is the underlying cause, and probably that's why the child is getting admitted and ventilated time and again. Because in this whole case, I didn't find that whether this child had been investigated for this chronic lung disorders like cystic fibrosis and mucociliary dyskinesias. So then, as I've told you, that nutrition, physiotherapy, hydration is very important. Along with, like, I still remember a case then when we had a child of similar adenovirus infection. Uh, the child came to us around at 1.5 years of age. We intubated the patient. Patient went up to HFO. From HFO, gradually weaned to normal ventilation and was discharged after 1.5 months of hospitalization. Again, after 1 month, they came back again. Again was admitted. Again was ventilated for 4 5 days, and then was sent home uh, home on high flow nasal cannula. So we gave them the machine. We arranged the machine for them. The mother was the father was a OT technician in some hospital, so he was knowing the basic things. So they managed that machine at home. They arranged for oxygen at home, and child was on HFNC for almost 6 months. So the child was dependent on HFNC, and we gradually told them, we made them that this child nutrition should be well. So for initial 2 months, we even gave NG feeds to the child so that the weight started gaining. So after 2 to 3 months, as the child grew by around 2 kgs, the oxygen requirement came down, and gradually he was just kept on HFNC on room air only, and gradually they weaned off from the HFNC. And initially the weaning off was like for 2 hours he was off HFNC, and again for 2 hours he was on HFNC. Gradually, the HFNC time was reduced and the off time was increased. So this child was at home for almost 1 year. After 1 year, once the child was off oxygen, off HFNC support, he was then we allowed him to go to the social gatherings and to public places. Only home-based schooling or any small amount of whatever education exposure was required at that time, it was done at home only. Now, after 1.5 years of age, of 1.5 years of initial hospitalization, now the child was around 3.5 years of age. That time we allowed them to take out the child to some public places, to the social gatherings, and now the exhibitions were happening, but not like leading to hospitalizations or leading to any significant respiratory distress. So, bronchiolitis obliterans is a very tricky disease, rare presentation. Yes, but to diagnose it, that we have only clinical criteria like we have recurrent presentation, lot of spasms, lot of conductive sounds, and you get a CT done, and CT you get a mosaic pattern of the disease. But mosaic pattern of disease you will get in any case where even a severe bronchiolitis, not going up to the tune of bronchiolitis obliterans. If you get a CT done, you will get similar kind of mosaic pattern. So if this mosaic pattern is persisting and the clinical picture is same, it is not improving, or the child is symptomatic and you have to send this patient on home care oxygen basis, then you should start thinking about bronchiolitis obliterans. And now the dictum is any child is suspecting bronchiolitis obliterans, get clinical exome sequencing done to know the genetic basis, whether still it is a post-infectious or probably you are dealing with acute exacerbations on and above of any chronic lung condition like cystic fibrosis or mucociliary dyskinesias. This clinical exome sequencing has made the life easier. Only problem is that the report comes after around 40 days, but the cost has come down to just 5,000 rupees. So it's not a very costly test. You can, at the cost of one CT scan, you can get this clinical exome sequencing done, and you will be surprised that many of these patients whom we were labeling that probably this is a post-infectious one, they have some genetic basis of this disease also. So I think now the house is open to the questions. If anybody wants to ask any questions to Dr. Dipanshu about the case and to me anything about how to manage it, so we can discuss it.
Request to all the residents or our senior consultant pediatrician who else joined can ask any comments, questions, input. I think first question from a PG should be how you reached bronchiolitis obliterans, why it is not otherwise where is the differential diagnosis slide, and what were the points for and against for each diagnosis? Why this is not persistent, recurrent? Why this is bronchiolitis obliterans? From like rest questions, also I request anyone to open, switch on their camera and mic if possible.
I think
It's okay.
if I will answer this question is, then any case of bronchiolitis, as I told you, if you see 100 cases of bronchiolitis, then you can say that probably one you will find bronchiolitis obliterans. And bronchiolitis obliterans is clinical diagnosis only. You don't have any test on which basis you can say that this is bronchiolitis obliterans, because what is obliterans? Obliterans means your small bronchioles are getting obliterated because of the inflammation of your mucosa, and the inflammation leading to shedding of the mucosa, and this shedding leads to blockage of these small bronchioles, where now they are behaving like a obstructive lung disease. Now, in bronchiolitis also, this is the same thing is happening. But as bronchiolitis, we know that it's a disease of around 5 to 7 days. If everything gets cleared off, the thing starts getting normal and the child is sent home in a normal condition. But if due to some reason, like one is increased severity of the infection, first point. Second is persistence of the infection in the lower bronchioles, and persistence of the inflammation in this lower bronchioles. We all know that if anywhere inflammation persists beyond 7 to 10 days, this leads to fibrosis. And when the fibrosis happens, that means now the bronchioles doesn't have the capacity to dilate or constrict. Now these bronchioles are fibrosed and they are narrow. So whenever small amount of secretion happens in these bronchioles, this will actually cause symptoms in these patients. Now symptoms, I mean, they will have chronic cough, productive cough, distress, and oxygen requirement. So now how to diagnose? We do a CT scan when the symptoms are persisting, when the patient is not improving, or patient is worsened, or patient requires ventilation, and even after extubation of the from the ventilation, that there are recurrence of symptoms are happening. So whenever we are actually labeling it as bronchiolitis obliterans, so we should be labeling it due to which it has happened. So one is commonest cause of bronchiolitis obliterans is post-infectious. Second is the chronic lung conditions, which can also lead to bronchiolitis obliterans. So bronchiolitis obliterans is a clinical stage where the patient has reached. We need to find out the cause, what has led to this clinical stage which the patient has reached. So cause is always important, as I told you, that we should be able to know, like in this patient, initially managed in PGI, where they did the viral PCR at the bedside and they found it is adenovirus induced. Second is, if the persistence is happening again and again, we should also do some genetic testing, where exome sequencing, nowadays we routinely send exome sequencing, and that gives us a possibility that probably some chronic lung condition is happening, like I told you, cystic fibrosis, or any mucociliary dyskinesias, or any bronchiectasis has also a genetic basis where you can label that this is a chronic lung condition. Now, another thing is, once you have reached that this patient is having time and again symptoms are present and the patient is getting admitted again and again, so our treatment should be based on how to reduce these aggravations. So we have, as I told you, we have to work on all the aspects. We have to reduce this child from exposure to getting infected again and again. Now, from where the child is getting infections, either from the family members, or if we are taking the child out in social gatherings or in schools, from where the child is getting infection from his peer group. So we have to avoid it. And till what time? Till the time the child becomes clinically asymptomatic. Asymptomatic means the child is not having infections again and again, or the child is not having symptoms in form of the child's chest is totally clear, no conducted sounds, child is not coughing now, not even a minor distress is present. And the distress means once the child is walking, running, also the child has a normal playing capacity. So to achieve this, we should avoid exposure of the child to the outside world for at least 6 months to 1 year, because we know that a child grows, new lungs will be formed, and that will help in the treatment of the infection if it has happened because of infection.
Thank you for some nice explanation. Anyone else, Dr. Radha, Dr.
Whatever the
Tarocham,
means are
sir,
available to us.
if yeah, any inputs from your side? Dr. Amardeep, ma'am, if any final comments from your side?
Ma'am, actually, we also tried to do the genetic testing for this child because of how we done in near about 5,000 rupees. We will do it. We will do it for our further patients. We can do that. This thing will less.
Yeah, no, cost has come down a lot, ma'am. Many labs are offering just 5,000 rupees. This exome sequencing is now available, easily available. So, but only the problem is turnaround time is around 40 days.
तो होल
Many
एग्जाम भी
times ना
10,000 का कर
we
रहे हैं,
advise
होल
them it
एग्जाम भी हो गया 10,000 का ही हो गया, एनजीएस 8 का, होल
how to
एग्जाम
try.
10 का। लाइफ स्टाइल मेडिजिन कहीं से भी करा सकते हैं। Okay, Dr. Ruby Singh has just joined, ma'am. Any inputs? We have bronchiolitis obliterans. Okay, fine. If there
I'm
there
sorry I missed quite a bit because the information I received around 150. So I just saw the message and I just joined. So I'm
no,
extremely
absolutely,
sorry. Not much.
absolutely fine. Okay, fine. Thank you for an excellent presentation and expert input from our senior pediatric intensivist, Dr. Vikas sir. Thank you so much, everyone, for joining the session. And the recordings will be available on our Sapa YouTube channel. I'm extremely thankful to all who joined here, and still the recordings will be available. Who couldn't join, they can like, subscribe, share our
We are
Sapa
also
channel.
thankful to you, ma'am, for giving us this platform.
Yeah. Thank you so much, ma'am. Thank you.
Thank you. Thank you, everyone.
Okay. Thank you so much. Thank you, sir.
Thank you, ma'am.
Thank you.
हो गया. हाँ, क्या हुआ? Why you didn't come on the?
मैं पूरा दिन हल्का हल्का नाशा हुआ था, मेरा पेट पे हल्का हल्का